Hey, what's up guys? J.A. here with Physical Therapy Clinical Development. In this video, I'm going to cover everything you need to know about lower body neurodynamics. Specifically, I'm going to talk about selective tensioning techniques for the peroneal, tibial, sural, saphenous, femoral, obturator, and lateral femoral cutaneous nerve. On top of that, I'm going to talk about how you can do nerve glides and nerve tensioners as a clinician, as well as self-care strategies for your patients. For the peroneal nerve tension test, we need to put the foot into plantar flexion and inversion. Next, we want to take the patient's leg into a straight leg raised position. If we want to add more tension, we can adduct the leg as well as internally rotate this. Now, if you know your anatomy, it makes it a lot easier to know how to selectively tension. Let's take a look. Now, the peroneal nerve is a branch of the sciatic nerve, and if we look closely, we can see how the peroneal nerve comes down and around behind the femur and around the fibular head. If we look at the distal branches of the common peroneal nerve, we can see that these nerves sit on the anterolateral aspect of the ankle. So it only makes sense that if we plantar flex and invert that ankle, we're going to put more tension through the branches of the common peroneal nerve as well as the peroneal nerve itself. For the tibial nerve tension test, we're going to put the foot into dorsiflexion and ankle eversion as we bring the patient's leg into a straight leg raised position. Again, let's take a look at the anatomy and better understand this. The tibial nerve is again a branch of the sciatic nerve. Now the tibial nerve, instead of deviating off to the lateral part of the leg, stays mostly central until we get down to the foot and the ankle when it takes a dive medially. Thus, when we evert and dorsiflex, we put tension on the tibial nerve. All right, so for the sural nerve tension test, we need to put the foot into dorsiflexion and inversion, followed by a straight leg raise. We can add adduction or internal rotation to put more tension through the nerve. Again, this comes back to knowing the anatomy. If we understand where this nerve goes, we know how to tension it. So the sural nerve is going to run posterior to the knee joint and posterior to the ankle joint. Thus, dorsiflexion becomes an important component of tensioning this nerve. Additionally, it's on the lateral part of the lower leg, so inversion will put more tension through this nerve. We can tension the femoral nerve in two ways. This is the prone knee bend. In the next video, you'll see the side-lying slump position, which also tensions this nerve. When we look at the anatomy, we can see that the femoral nerve crosses anterior to the hip joint, thus requiring at least neutral hip extension to selectively tension this nerve. If we look at the distal branches, we can see that ultimately these branches will go anterior to the knee joint. Thus, a good amount of knee flexion plus hip extension is important in order to tension this nerve. This is the side-lying slump position I mentioned in the previous video. For the femoral nerve, we will take up knee flexion and hip extension. For the obturator nerve, we will place the hip in abduction. Now, if we understand the anatomy, which we'll see in a second, this makes sense. The obturator nerve sits anterior to the hip joint and is on the medial thigh. Thus, extension and abduction will tension this nerve. The lateral femoral cutaneous nerve can be selectively tensioned by using the side-lying slump plus hip adduction. Because of this nerve's position, which is anterior to the hip joint and on the lateral aspect, extension and adduction will tension this nerve. In order to selectively tension the saphenous nerve, the patient's leg should be abducted and the hip extended. The flexed knee will be extended and the leg laterally rotated. The ankle should be everted and dorsiflexed. If we look at the anatomy, this makes sense. The saphenous nerve sits anterior to the hip joint and posterior to the knee joint, thus requiring extension at both joints, as well as the fact that this nerve lies medially along the lower leg. Thus, abduction and eversion are important components of tensioning this nerve. So there's a couple different ways in which we can treat the peroneal nerve using clinician-assisted techniques or treatments. So to start, we're going to put the person's foot into plantar flexion and inversion while we bring them into a straight leg raised position. Now, if we want to glide the nerve or do a slider, we can simply dorsiflex and plantar flex at the foot. We can also add cervical movements in order to put more or less tension on the nerve. In this case, as we plantar flex and extend the neck, this would be a nerve slider. As we dorsiflex and flex the head and the neck, this would be a nerve tensioner. So clinician-assisted treatments are great, but we want the patient to be able to perform these at home. And so we're going to start with the patient in supine to perform a tensioner or a slider, depending on what the head and the neck do at the same time as the knee. In this case, with the foot plantar flexed and inverted, and the knee extending and the head extending, we're gliding the nerve. If the patient were to extend the knee and flex the neck at the same time, that would be a tensioner. A forced progression would be a leg swing with the foot in plantar flexion and inversion. You can always add cervical movement to increase or decrease tension. To further progress peroneal nerve glides, we can do this standing mobilization. In this case, the patient will plantar flex and invert the foot as it comes back and across the body. Cervical and lumbar movements can be added for more or less tension. A more intense mobilization of the peroneal nerve would be the wall slide mobilization. In this case, the strap is holding the foot into plantar flexion and inversion, while the knee flexes and extends. Again, we can always add cervical flexion or extension to facilitate sliding or tensioning. Lastly, we can progress the peroneal nerve tensioning or sliding to a standing hamstring stretch. In this case, the foot is in plantar flexion and inversion. Again, we can always add cervical flexion or extension as well as lumbar flexion or extension to change the amount of tension in the nerve. In this particular case, you can also move distally at the foot and the ankle to create more or less tension along with cervical movements. So the clinician-assisted treatments for the tibial nerve are going to look very similar to the peroneal nerve. The only difference is the position of the foot and the ankle. So again, with the tibial nerve, we want to evert and dorsiflex. In this case, we can add cervical flexion and extension to glide or tension. We can also take the patient and put them in a 90-90 position, pre-position the foot into eversion and dorsiflexion, extend the knee, and then plantar flex and invert to glide that nerve. Much like the peroneal nerve, the tibial nerve has a progression of nerve mobilizations progressing from gentle to more aggressive. In this case, with the patient supine, we would pre-position the foot in eversion and dorsiflexion and work the knee into flexion and extension. In order to glide the nerve, we would extend the knee while we extend the neck. In order to tension, like you see here, we would extend the knee and flex the head and the neck. The leg swing mobilization is another great way to mobilize a tibial nerve. The foot will be pre-positioned into eversion and dorsiflexion, while the hip swings through flexion and extension. To progress forces, we can use the wall mobilization. In this case, the patient would evert and dorsiflex the foot with the strap sustaining this foot position. Neck flexion can be added to knee extension for tensioning, or neck extension added to knee extension for gliding. The final progression to tibial nerve mobilizations would include the standing hamstring stretch. In this case, the foot is pre-positioned in eversion and dorsiflexion, while movements are performed at the hip, the lumbar spine, and or the cervical spine. These movements can be performed while the foot and the ankle are also moving, again, to tension or glide the nerve. Clinician-assisted treatments for the sural nerve can be done in supine. In this case, the foot is dorsiflexed and inverted while the patient is taken into a straight leg raised position. From here, foot and ankle movements can be done in combination or in isolation to mobilize the nerve. The patient may also be placed in a 90-90 position with the hip in flexion. In this case, the foot is pre-positioned into dorsiflexion and inversion, while the knee is flexed and extended in order to glide or tension the nerve, depending upon what movements happen both proximal and distal. Self-care for the sural nerve may include any of the mobilizations you've seen up to this point by simply manipulating the foot position to include dorsiflexion and inversion. In this case, this is a supine glider happening with neck extension and knee extension. To progress to a tensioner, one could extend the knee while also flexing the neck. For the femoral nerve, clinician-assisted treatment can be performed with the prone knee bend or can be done in side-lying in the side-lying slump position. From here, the knee is flexed and the hip is extended. Gliders or tensioners can be facilitated by proximal movements in the head and the neck. Simply adding hip adduction can target the lateral femoral cutaneous nerve, while adding hip abduction can target the obturator nerve. There are a few options for self-care treatment of the femoral nerve. First, the patient can just lie prone on elbows. A progression can be added by performing knee flexion. In order to glide or tension the nerve, cervical movements can be incorporated to facilitate this. To progress femoral nerve mobilization, a Thomas test position may be used. In this case, the right hip is an extension with the knee in flexion, putting tension on the femoral nerve. Cervical movement can be used to mobilize the nerve. Lastly, the femoral nerve can be mobilized in what's called the hurdler position. In this case, the left leg is in hip flexion and knee extension, while the right leg is in extension. With the knee moving and the head and neck moving, we can facilitate mobilization of the femoral nerve. In order to mobilize the saphenous nerve as a clinician, you're going to want to place the patient in the same position as our test for the saphenous nerve. So hip extension, abduction, knee flexion, ankle dorsiflexion, and eversion. From here, the knee will be extended to put tension on the nerve. By repeatedly moving into flexion and extension at the knee, as well as moving in and out of internal and external rotation, the saphenous nerve can be mobilized. For self-care, the foot will be placed into eversion and dorsiflexion by way of a wedge. The body will lean away from the leg, causing an abduction moment at the hip.